This conference will now be recorded.
Okay. Good morning, everyone. Today, my topic is about blood transfusion. So, today we will be discussing about these topics, that is history, preparation of the blood components, storage, indication of blood transfusion, and what are the important components of blood, when do we do prophylactic transfusions, when do we do massive transfusions, and what is the transfusion reactions. Okay. So, history of transfusion. When was it first transfusion? When was this concept started? At first, well, since mid 1600s, blood transfusion has been started. First successful transfusion is done in 1828. That is mostly first they have experimented on dogs, then later on human. So first there was a king who started this type of transfusion. He took the blood from the small children and then transfused it to himself. Okay, this is how the first transfusion started. So in 1900, Landsteiner described the ABO type of blood grouping. In 1916, he first usage of blood storage is done. In 1939, Levin described the RH factor. Okay, this is the century during this 1900 century. So what events took place regarding blood transfusion? That is, in 1900, Landsteiner discovered the ABO type of blood grouping, and the 1920s plasma collection began. And in 1950, the plastic bags which used to collect the blood were invented. And in 1972, they started testing for the hepatitis B virus. And in 1983, first the hepatitis HIV virus first was discovered. Then in 1985, they started testing for the HIV. In 1986, cellular therapy emerged, and in 1989, leukoreduction began, and 1990, artificial blood was developed first, and it's transfused. And in 2000, safety type of transfusion is done. Excuse me. So, what is blood transfusion? Blood transfusion is the transfer of blood or blood products from one person into the other person bloodstream, that is recipient. This is usually done in a life-saving manner to replace blood cells or blood products lost to severe bleeding during surgery, or when there is, or during RTA, or blood loss occurs to the increase of blood count in the anemic patient. So the safest blood product is your own is the safest for transfusion, but unlikely we won't transfuse ourselves now. So before, unlikely we won't give the blood to the hospital and then take it. So unfortunately, this option is usually only when practically or for elective surgery only. So in most of the instances, the patient cannot donate their own blood due to acute nature. So autologous blood, when using your own blood, that is preoperatively donating your own blood before the surgery, that is either 2 months or uh, 3 months. This option is only for non-emergency, that is elective type of surgeries. It has the advantage of eliminating or minimizing the need for surgery. That is required planning. So I have told you now, that is 2 or 3 months before, prior to the surgery, the patient must give his own blood, then later followed by surgery, so that he can develop his own blood and he can sustain, he can develop some resistance and stamina during the surgery, and then later post-operatively, again he must that blood is transfused to himself. This is rarely done. This type of autologous type of blood transfusion is rarely done, because when the patient comes to our surgery, he must be having some pathology. So in that pathology, despite that pathology, we must take his own blood. So the HB level, the other component level, the other immune systems may be somewhat compromised in that surgical patients. So this is rarely done. Okay. So what are the blood components? Whole blood and blood components and RBC, platelets, fresh frozen plasma, leukocyte concentrate, and plasma substitutes. So whole blood. Uh, when do we give whole blood? For severe blood loss, that is, it contains red blood cells. What are the components of whole blood? That is one red blood cell and one plasma and platelets. So in red cells for surgical trauma and patients as well as people with anemia, such as in case of dialysis, they will be having a severe loss of red blood cells. So they can be stored and refrigerated for 42 days. So what are the uses of plasma? It is used to treat the victims of burns, shock, and dehydration. So it can be frozen and stored for up to 1 year. So cryoprecipitate, which is taken from the plasma, it is used to treat the patients with coagulation disorders like factor 8 coagulation disorders, factor 12 coagulation disorder, Walm-Wheeler disease, such like that cases. We go for cryoprecipitates. So when do we give white blood cells? To help fight the infection, and platelets to control bleeding. They are given to help treat leukemia patient and cancer patients who are undergoing chemotherapy. Platelets and only last for 5 days. So coming to the storage of blood and blood components, and whole blood volume of the whole blood is about 350 to 450 ml. So it is stored in 2 to 6 degrees centigrade, and it's expired in CPD in 35 days. Okay, so up to 42 days we can store the whole blood maximum. So packed red cells, these contain 280, that is up to 300 ml or up to 350 ml. Okay, similar storage temperature for the packed blood cells is 2 to 6 degrees centigrade, and it is packed with CPD solution, that is citrate phosphate dextrose with adenosine, and its also lifespan is about 35 days, maximum up to 45 days, 42 days. Platelets, so the volume of the platelets is about 50 to 70 ml, and packed cells is other platelet type of cells is 70 to 90 ml, and it is normally stored at room temperature, that is 2 to 24 degrees. That is with agitation, means that is continuous movement of the platelets, that is they won't coagulate. If there won't be any agitation, or if they're stagnant, the platelets will get coagulated, so they will be continuously agitated. So the storage time is for 5 days generally. uh, Within separation from the whole blood, these platelets are transfused immediately. Okay, so and plasma, it contains about 200 to 220 ml, and the storage temperature for this is 30 degrees centigrade or below. And start is stored is about 2 to 6 degrees centigrade. So frozen, it can be stored up for 1 year, and the third one can be stored up to 12 hours. So cryogenic and is about 3 to 20 ml, and frozen for about 30 degrees centigrade or below, and which can be stored for up to 1 year. And the third is about 2 to 6 degrees centigrade, which can be stored for up to 6 hours. So rational use of blood products. So it must be right product. They must contain the right dose, and it must be given at the right time only, not before or not after. And it must have component reasons or specific reasons or correct reasons for the storage of the for the transfusion of the blood. Okay. So what are the indications for the uh, whole blood? Patients having symptoms decrease in oxygen carrying capacity and combined hypovolemic sufficient degree associated with any shock, that is septic shock or hypovolemic shock or any other type of shock. So in major trauma surgical operation, a blood loss up to more than 30 degrees and 30% and risk of hemorrhagic shock is seen. Even in most such cases, transfusion in combination of the crystalloid and red cells or red cells and fresh frozen plasma provide both volume expansion and oxygen carrying capacity. Okay. So platelets. About 80 to 90% become non-functional in 24 hours. So platelets immediately separation from the whole blood must be transfused. So they have the potent action within the 24 hours. So rapid clearance from the bloodstream after transfusion. Due to clustering of the receptors or platelets, they cannot be transfused beyond 24 hours. So they must be agitated continuously for 24 hours. So better to ideally is to transfuse within the 24 hours only. So clotting factors, it is the 30 to 40% level coagulation factor, that is factor 5 and factor 8 are lost in 24 hours. Okay. So within 24 hours only, that is the priority. So indication for the packed blood cells, that is when it is given. So in decreased bone marrow production and in leukemia and aplastic anemia, it is given. So decreased red cell survival indicate conditions such as hemolytic anemia and thalassemia. These all you may be knowing from the physiology, pathology, and this in these all conditions you will be giving. In bleeding conditions such as surgical bleeding and traumatic bleeding. In mainly in surgery, we give blood transfusion because if the patient is any anemic or the patient is having any surgical bleeding which is uncontrolled bleeding or heavy loss of bleeding due to any trauma or due to road traffic accidents or any other type of accidents, and if the patient is not fit for surgery, when the patient is having hb less than 8 gram per deciliters. So the during this condition, when the patient is having less than 8 or if this patient is clinically anemic, then we give packed red cells. So patient HP between 8 to 10 with disease need transfusion of red cells. Okay. Everything related to book is not at all not that much of important because we take reference from the textbook, but clinically the patient is anemic only, then we go for blood transfusion. Okay. Advantage of transfusion of red blood cells, that is when do we give, what are the advantages? To reduce the risk of circulatory overload and to lessen the severity and incidence of allergic reactions, and ABO antibodies are reduced, red blood cells non-ABO identical to patient group can be given, and removed plasma can be used for preparing FFP and cryoprecipitates. Contraindicated, it is contraindicated when well compensated anemic patients, nutritional anemia such as iron deficiency or pernicious anemia, response to iron and folic acid, to correct protein and coagulation factor and deficiency preoperative transfusion to raise HB above 10 grams per deciliter. So indications for platelet transfusion. When do we do platelet transfusion? That is, platelet count is less than 5,000 regardless of clinical condition. Platelet count is 5,000 to 10,000 microliters. If there is increased risk of bleeding, that is during fever and sepsis, and patient platelet count is 10,000 to 20,000 if thrombocytopenic bleeding is there, like bleeding from mucous membrane using from surgical incision, scattered petechiae and ecchymosis are seen in the patient. Okay, that is disseminated intravascular coagulation. And in chemotherapy for malignancy count, and it is less than 20,000 per microliter, and DIC massive transfusion and surgical procedures which have platelet count less than 50,000, and major surgical procedures like CNS and ophthalmic where the platelet count is less than 1 lakh. So during surgery, that is normal standard surgical procedure less than 50,000, and major surgical procedures like CNS and ophthalmic, including abdominal procedures also sometime less than 1 lakh means we go for platelet transfusion. So a standard of 170 micron filters are recommended for administration, and ABO compatibility of between donor and recipient is of minor importance in platelet because RH incompatibility is not that much of importance. So red blood cells contaminated platelet concentrate should be considered given with cautions in female patients. That is RH allo immunization will be seen. So when do we contraindicate the platelet transfusion? During TTP, ITP, and heparin-induced thrombocytopenia. So in thrombocytopenic purpura, if the platelet transfusion is done, then the patient will have cardiac overload following life-threatening condition. So in these conditions, it is generally contraindicated. Okay. Surgery of invasive procedure when platelet count is greater than 50,000 per microliter, prophylactic transfusion not indicated. Dosage 10 to 15 ml per kg per body weight. Advantage of HDP over RTP is volume is greater than 300 ml, whereas RDP volume is about 50 to 60 ml. Leukocyte count is less than HTP, and RDP 10 to the power of 8 in each unit. Exposed the patient to only one donor, but in RDP there will be multiple donors. So in low risk of elimination is in, and HLA or platelet match donor can be prepared. Count increases by 30 to 60,000 and is high cost. RDP is low cost, where the count is by 5 to 10,000. Fresh frozen plasma. So, what are the components of fresh frozen plasma? All coagulation factors, that is 1 international unit per ml of each factor is seen, and its maximum component of fibrinogen, that is 200 to 400 mg is seen. And indication of fresh frozen plasma: active bleeding and multiple coagulations, factor deficiency in liver disease, thrombocytopenic purpura, and disseminated intravascular coagulation, etc. Coagulation of congenital any acquired factor deficiency in small children, it is seen. Okay. Contraindications: collar volume expander is seen, hypoproteinemia, source of immunoglobulin is seen when it is contraindicated, and dose is about 10 ml per kg body weight. So, what does it contain? It contains fibrinogen, 150 to 250 mg, factor 8, that is 880 to 100 international unit, 1 millibrand factor 40 to 70%, factor 8, factor 13 20 to 30%, fibronectin 55 mg is seen. So indications: hemophilia A, 1 millibrand disease, congenital or acquired fibrinogen deficiency. Dose is 1 unit per 5 kg body weight. So after the prophylactic transfusions, there is a substantial lack of evidence that mild to moderate abnormalities of the INR or APDT can be or should be used as an indication to administer the pre-procedure fresh frozen plasma. Profound thrombocytopenia is also a poor predictor of bleeding. Based on the published literature, pre-procedure transfusion are not routinely required in patients for INR less than 3. Okay, accompanied by platelet with greater than 20,000 platelet, accompanied by INR less than 1.7. So for patient with mixed coagulation disorder, the patient with platelet counts in range of 20,000 to 50,000 microliter, accompanied by an iron range of 1.7 to 3, they will go for mixed coagulation. So this much is these decisions are generally influenced by experience of the operator and that is surgeon, and technical factors such as anatomy of the and the disease related comorbidities. Okay, is not that much of not important. Okay, massive transfusion. When is massive transfusion? What is massive transfusion? That is replacement of the greater than one blood 1 liter of blood volume in 24 hours, or greater than 50% of the blood volume in 4 hours. Okay, so normally the adult blood volume is 70 ml per kg. Okay, so if we replace greater than that 50%, then we call it as massive transfusion. In children, it is defined as transfusion greater than 40 ml per kg, because the blood volume in children over 1 month old is approximately 80 ml per kg. Okay. So when is massive transfusion occurs? In settings such as severe trauma, if there is any aortic aneurysm rupture, if there is any surgery and obstetrics related complications, then we go for massive transfusion. If majorly it is done in aortic aneurysms only, rupture of aortic aneurysm. The goal is to manage the massive transfusion is early recognition of the blood loss, maintenance of tissue transfusion and oxygenation by restoration of blood volume and HB, arrest of bleeding including with early surgical and radiological intervention, judicious use of blood component and therapy to correct coagulopathy. So what are the parameters in massive transfusion investigation and monitoring? That is, temperature is must be normal temperature, body temperature, that is greater than 35 degrees centigrade, and acid base status should be normal where the pH should be greater than 7.2, when the base excess should be less than -6, and lactate should be less than 4 millimoles per liter, and the ionized calciums must be greater than 1.1, and hemoglobin, this should not be used along with the transfusion triggers and should be interpreted in context with the hemodynamic status, organ and tissue perfusion, and platelets should be greater than 50,000, and PT-APDT should be less than 1.5 of normal, and fibrinogen should be greater than 1 gram. So, what are the complications including massive type of blood transfusion? That is number of units transfusion. It is depending upon the number of units transfused and what is the rate of the transfusion. That is fast transfusion or the slow type of transfusion, delayed transfusion, and what are the patient factors affecting the type of transfusion. Some of the complications of massive transfusion include hypothermia, the dilution coagulopathy, hypocalcemia, citrate toxicity, hypomagnesemia, and lactic acidosis, hyperkalemia, and air embolism. So this is a protocol for massive transfusion, which is established by the University of the Michigan. So we identify and manage the bleeding, that is surgery or angiographic embolization, and if there is 4 units of RBC is given less than 4 hours. Uh, and ongoing and uncontrolled bleeding, clinical team activate MPP designated clinical context. This is of not that much of not important. Okay. And when do we do safe blood transfusion procedures? Every hospital should have written standard operating procedures for the administration of the blood products, like, and particularly for the final identity check of the patient, the compatibility label determining the patient ABI and RSD group, and unique donation number of the blood pack, and blood group of the blood pack, or the date of the collection, and the expiry date. These are the must and should procedure that you should check on the blood transfusion. Before the blood transfusion, the expiry date, the date the blood is received from the recipient, and what are the indications if the patient really requires or not, and the signature of the clinician performing the pre-transfusion identity check and the transfusion procedure. Okay, the blood bag should always be inspected for signs of any deterioration on arrival and before transfusion if not used immediately. Okay, if the patient is having delaying about 1 hour like that, then we have to store it immediately, and again before transfusion we have to check for the any sign of deterioration, and the discoloration of the blood pack and any signs of leakage indicates contamination and could cause a severe fatal reaction if transfused. What are the transfusion reactions? Any adverse effect or unfavorable consequence occurs during or after transfusion. Types is acute within 24 hours, delayed after 24 hours, and immunological and non-immunological type. Acute hemolytic transfusion reaction, accelerated clearance or lysis are transfused red blood cells due to immunological compatibility, and etiology, majority of the reactions due to incompatibility red cell transfusion, clinical errors and technical errors. Okay, and few reported during FFP and platelet transfusion and occurs within minutes after transfusion. So what are the pathophysiology? Interaction of the antigen and antibody, and IgM antibody and complement activation, cytokine production, and histamine serotonin secretion. These are the pathophysiological process that occurs. You might have learned in pathology. So what are the signs and symptoms? Basically fever, chills, facial flushing, chest pain, flank pain or back pain, and hypotension, abdominal pain, dyspnea, vomiting, and hemoglobinuria. These are clinical. These are blood investigations include hemoglobinuria, hemoglobinemia, shock, anemia, oliguria, or anuria, disseminated intravascular coagulation. And in anesthetized patient, diffuse bleeding from surgical site, and hypotension and hemoglobinuria. So, what are the immediate management? When you see any transfusion reactions, we should stop transfusion. Then immediately therapeutic intervention include hydration to prevent renal impairment and to maintain output greater than 100 ml per hour, and normal saline and or 5% dextrose 200 ml per meter square per hour. So alkalization of urine to prevent renal impairment and to maintain urine pH greater than 5. So what is the dosage? Sodium bicarbonate is given 40 to 70 milliequivalents in 1 liter. So and diuresis should be done to prevent renal impairment, and mannitol is given, that is 20%, or furosemide 40 to 80 mg. So vasodilatation increase the renal blood flow, and dopamine by giving dopamine 1 to 5 micrograms per kg per minute. And anticoagulation to treat intravascular coagulation, heparin to be given 5 to 10 units per kg per hour is given. And red cell exchange transfusion to decrease the load of incompatible red cells. So exchange of one estimated red cell packet. And plasma platelet transfusion treat hemorrhagic complication or disseminated intravascular coagulation. Platelet 1 unit platelets per 10 kg or 1 unit FRCs platelet. And intravenous immunoglobulin prevent extravascular hemolysis. Okay. So febrile non-hemolytic transfusion reaction (FNHTR). So increase in body temperature of 1 degrees centigrade or more that occurs during or within several hours of transfusion. Generally 1 to 4 hours the transfusion occurs. Within this type of transfusion, if there is any rise in temperature that is greater than 1 degree centigrade, we call it as febrile non-hemolytic and is unrelated to hemolysis or sepsis or other known cause of fever. The fever of usually persists no more than 8 to 12 hours after starting the transfusion. If fever persists 18 to 24 hours or longer, it is unlikely to be transfusion related. And generally, these are self-limited and have no sequelae. Transfusion of the cellular blood components indicated by for febrile non-hemolytic transfusion reaction, that is leukocytes and cytokines. And signs and symptoms include fever without chills and rarely hypertension. In severe cases, chills. Treatment and prevention include shock transfusion, antipyretic, acetaminophen, and in case of severe shaking chills and meperidine. Prevention includes leukoreduced blood components. And common reaction include foreign protein in donor plasma react with IgE in the patient. This is about allergic type of transfusion reactions. Include donor plasma Ig combined with allergen in the patient and stimulates the mast cells and basophil causing inflammation. It causes allergy and the release of the histocytes and cytokines. And signs and symptoms include local erythema, that is over the transfusion site, and pruritus, whole body itching, a high fever may or may not be present. Rarely severe is angioneurotic edema, laryngeal edema, and bronchial asthma. Okay, this is a life-threatening condition, and the treatment is include immediately stop the transfusion and release of and giving him antihistamine injections, diphenhydramine or evil like this, such like that, just the trade name. And the severe cases include infusion of the corticosteroids and the mild reaction restart. If the reaction is very mild and is not life-threatening, then we can restart the transfusion of the blood and blood components and observe carefully this time. So prevention is prophylactically we give antihistamines, that is Evil or diphenhydramine 1 hour before only transfusion, and the repeated reactions plasma removed by cell washing. So anaphylactic reactions it include immediate hypersensitivity of the immune system, range from mild urticaria to severe shock and death, fever absent and starts immediately after transfusion, few ml per of plasma, congenital IgA deficient patient have Wing IgA antibodies. Signs and symptoms include respiratory tract, cough, bronchospasm, dyspnea. GI tract include nausea, vomiting and diarrhea. Circulatory system include arrhythmias, hypotension, syncope, and skin changes include generalized flushing and urticaria. So the treatment includes stop transfusion immediately, maintain IV line with NS, injection epinephrine, subcutaneous or IM, maintenance of airway, severe reaction and corticosteroids with aminophylline, and prevention by RBC washing, and plasma for IgA deficient donors. TRALI, transfusion related acute lung injury. It is a non-cardiogenic pulmonary edema of pulmonary hypersensitivity reaction or allergic pulmonary edema. So leukocyte antibody in donor or plasma patient plasma include leukocyte antibody, reaction with leukocyte, activation of complement system, activation of basophil platelets, histamine and serotonin release, leukocyte embolia and aggregating lung capillaries, and interstitial fluid in alveolar space. This is the process of lung injury where the continuous accumulation of the interstitial edema in the alveolar space after the activation of the complement and basophil systems. Okay. What are the signs and symptoms? It includes chills, cough, sinuses, and fever, uh, hypertension, increasing in respiratory distress, X-ray shows bilateral pulmonary infiltrates. Diagnosis of exclusion include heart failure, cardiac overload, and bacterial sepsis. This may be the differential diagnosis. And treatment includes supportive care, that is airway maintenance, IV corticosteroids, but they are that much of not effective. But we transfuse them it to the patient. So it's still a question mark to the treatment in the line of treatment of TRALI. So usually pulmonary sufficiency returns within 10 to 12 hours. So prevention include leukocyte poor components. So bacterial contamination reactions include rare but have rapid onset and death, and it starts immediately or within 30 minutes of transfusion. So endotoxin are released during the storage. That is why this endotoxin are also transferred to the patient. So most common in platelet transfusion, that is when the platelets are stored at room temperature. And Yersinia enterocoletica, Pseudomonas species, E. coli, these are the most commonly seen bacterial contamination. Signs and symptoms include dryness and flushing of skin, fever, hypertension, chills, muscle pain, vomiting, diarrhea, hemoglobinuria, shock, renal failure, and dick. So treatment include immediately stop the transfusion, maintain the IV line, broad spectrum antibiotics, that is high power. It should be given immediately. And therapy for shock, steroids, and vasopressors. Then we send the patient blood for culture to rule out the type of blood infection or the type of bacteria. And fluid maintenance and fluid support therapy must be done, and respiratory ventilation patient must be placed. So maintenance of the renal function by giving him dopamine or epinephrine, and prevention is by strict adherence to all blood products. So that's why we must check the patient blood packet before transfusion. Transfusion associated circulatory overload, that is TACO. It is seen in iatrogenic transfusion centers reactions. So risk group are young children, elderly patient, and patients with chronic non-metabolic anemia and cardiac disease. When it is seen, when the transfusion occurs at a faster rate, then hypervolemia due to transfusion occurs, followed by congestive heart failure, followed by pulmonary edema. So signs and symptoms include dyspnea, coughing, sinuses, tachycardia, hypertension, increased central venous pressure. And treatment include reduction of the hypervolemia, IV diuretics, respiratory support, oxygen therapy, cardiac support, and therapeutic phlebotomy. Prevention include plasma reduction, slower rate of transfusion. Delayed hemolytic transfusion reactions occurs in primary alloimmunization, occurs several weeks after transfusion and mostly mild due to incompatibility of RH, KEL, Duffy kit, and other systems. These are the types of RH systems incompatibility. So secondary or anamnestic response is seen in transfusion or incompatible RBC. So signs and symptoms include mild fever, fall in hemoglobin, rise in bilirubin 5 to 7 days after transfusion, renal failure very rare, and treatment include transfusion with blood component. Post transfusion, as a result of anamnestic products, uh, usually occurs in multiparous female and 7 to 14 days after transfusion. Antibodies, specifically HPA-1A, and signs and symptoms include fever, chills, and dyspnea. Severe cases generalized purpura, hematuria, melena, and vaginal bleeding. And treatment include corticosteroids, plasma exchange, and intravenous immunoglobulins. Phenomenon that occurs after blood transfusion in which donor T cells responding to protein on host cells, proliferation and target host organs, primarily the skin, liver, and the intestinal tract and marrow. Then the risk group include lymphopenic and bone marrow suppressed patient, very low birth weight, premature infants, critically in patients and receiving extracorporeal membrane oxygenation, individual with congenital immune deficiency, and recipient of blood transfusion for family members. Okay. So requirement to develop a graft versus host disease, graft must contain immunological competent cells. There must be antigenic difference between the donor and the recipient. and the recipient must be able to mount an effective immunological response and eradicate the transplanted immunological competent cells. The presentation uh, of the host reception, host protein T donor T cells of antigen presenting cells, donor T cell activation, proliferation, and migration, and host target tissue damage. So, what are the signs and symptoms? Include same similarly, that is the fever, skin rashes, hepatitis, diarrhea, bone marrow suppression, infection. So, iron overload. This is most commonly seen in transfusion-induced hemosiderosis. Each unit of red cell contains 225 mg of iron. Occurs in chronic transfusion-dependent patient, congenital hemolytic anemia, aplastic anemia, and chronic renal failure. Iron mainly affect heart, liver, and endocrine glands. Signs and symptoms include muscle weightage, fatigue, weight loss, mild jaundice, anemia, mild diabetes, and cardiac arrhythmia. Treatment: subcutaneous description and therapeutic phlebotomy. Prevention include one promising strategies. Okay. So these are the most commonly transfusion transmitted infection. It includes HIV, hepatitis B, hepatitis C, malaria, syphilis. HIV within 5 days, hepatitis B transfusion within 25 days, and hepatitis C within 5 days. So right now, up till now, this is enough. Next class we'll continue later. Okay. Thank you.